I think we need to better understand the differences in the adverse event profiles between BTK inhibitors, specifically those second generation BTK inhibitors, zanubrutinib and acalabrutinib. As more data matures for zanubrutinib, I'm curious to know, do we then see more equivocal cardiovascular risk profiles between the two, or does zanubrutinib continue to show that the atrial fibrillation risks are less than acalabrutinib? Additionally, we want to better optimize treatment duration with venetoclax, and specifically for those patients with high-risk disease, including 17p deletions and TP53 mutations. As Amber had pointed out, these patients do have shorter progression-free survivals in the CLL14 data. And so the question remains, would they have improved progression-free survival if we do a longer course of venetoclax? Does it matter either way? And is time-defined duration treatment appropriate for those high-risk patients? I think additionally in the future, we need to better optimize how we give venetoclax, especially since we don't see as much tumor lysis anymore with the advent of the 5-week dose escalation and including debulking agents prior to starting the dose escalation, such as obinutuzumab. For those patients in rural communities, is there a better way to give this regimen, an easier way to give this regimen in the community to allow them better access? And then lastly, the age-old question of how do we sequence all these drugs? All of these drugs are listed in the NCCN guidelines as approved for frontline treatment and in the relapse refractory setting. And right now, I don't think there is a clear answer as to whether doing one drug first benefits the patient more than the other. But as we get more data, particularly with giving patients BTK inhibitors after venetoclax, because we have more data with giving venetoclax after BTK inhibitors, will that sort of change our approach and make us lean towards one or the other?